While you're sitting down, although Mead gave very nice introductions, I'll elaborate just a little bit, starting with Lori, who is a senior fellow at the Council on Foreign Relations, and I like this in her bio. She's the only writer ever to have been awarded all three of the big P's of journalism, the Peabody, the Polk, and the Pulitzer. So that's great. And Lori is actually a biologist. I think it's fortunate that she stumbled from biology into journalism, particularly on global health issues. Ambassador Jimmy Coker is here now. It's hard to keep track of what he's representing, but he's now at the Department of Health and Human Services. He has been at PEPFAR. He has been at UNICEF. He was an ambassador to Uganda and Burkina Faso. He's a political scientist, so I hope he'll say something about the political economy of Mead's proposals. Ken Leonard is an economist at the University of Maryland, and he works especially on delivery issues. That's very important, very central now in development economics. I think of it sometimes as implementation science. It's time to move on from what should be done in a policy sense to how to get it done in terms of implementation. He has worked extensively in Africa, especially including Cameroon, Ethiopia, Gabon, Kenya, and Tanzania. And finally, David Wilson is here, and I'm thankful to him. I think he just got off an airplane. Not sure, but I know he's recently arrived from somewhere. David is the director of the Global HIV/AIDS Program at the World Bank. He's the one who corralled me into moderating that debate the other day, in which I learned a tremendous amount. David has been at the World Bank for how many years? Some years, guiding its work in HIV/AIDS. He taught at the University of Zimbabwe. He's from Zimbabwe for 20 years, where he served as professor and departmental head. So what we're going to do is give each person 3 minutes. I'm going to try to be tough, to say something to get us started, perhaps in reaction to the book itself and or to Mead's specific presentation. And then I'll try to have some questions and interchange with them and amongst them. And then we'll turn to all of you for your questions and comments. So shall we just go down the lines, ladies first, starting with Lori?
Thank you, Nancy. And in my very brief moments here, let me just go through a few key things. First of all, I think there was a time in the early days of the HIV/AIDS epidemic when there were really only two economists on the playing field doing anything that really mattered, and Mead was one of those two. And I don't know how we would have made it through the early days of dark days of this pandemic without Mead's input. Truly extraordinary. And anybody that finds this book controversial, and I think you'd be nuts not to, I challenge you to go to page 25 and look at that chart and tell me what the other answers are. And frankly, to go through the first roughly 70 pages of the hard data that Mead's crunched on what it would cost, to reach 80% uptake, he's looking at almost $500 billion. If you can figure out a way to do it cheaper, please do let us know. But I want to go through a few key points. First of all, I think donor support is going exactly the wrong way, and most of the data, if you can get your hands on it, for the last 12 months is extremely grim. We're now getting reports of collapsing HIV prevention and treatment programs in Portugal, in Greece. We're getting a very widespread information regarding particularly programs for IDUs in Western Europe, really getting undermined very rapidly. And well, you will have to see where we stand in about 6 months, but it so far is looking to me anyway like real disbursement versus commitment is way out of alignment, much worse than we've seen in the past. And there's not really a large appetite for putting HIV/AIDS front and center on the global agenda on the part of the likely donors. Second big point and concern on my part is that what this has resulted in so far is not so much a net decrease that we can really wrap our hands around in the total lump sum out there for what we could call global HIV programs, but a very severe skewing in the donor scene, so that the entire world is really dependent on two major donors. 68% of all private funds come from one human being, Bill Gates. Thank you very much. No board, no appeals process, no transparency. That's that donor. Then 52% of all global health funds from public donor comes from the United States government. 58% of all HIV publicly donated funds come from the United States government. So thank you very much, Ileana Ross-Layton, Kay Granger, etc. Let's just hope somehow miracles occur on Capitol Hill, and we're counting on Jimmy, and we'll see where that all goes. But clearly, we are looking for creative financing, and we are looking for a better match between donors' input and outcomes, measurable outcomes. And this whole search for measurable outcomes is where the Global Fund is now in very deep trouble. And unless they can demonstrate within the next 12 months that they really do have measurable outcomes and accountability on all their funding, I think we're going to see a real further walk away from the major donors. Even if the United States hangs in there, I'm not sure the rest of the Europeans will. Okay, now, as for specifically what Mead is recommending, I first of all have never believed a single data point that is described as averted infections. I don't think we have any way of measuring that I trust. It's sort of asking UNAIDS to measure averted infections is like asking the American Cancer Society to measure impact of public health programs on decline in cancer. You know, they have a vested interest in demonstrating that they've been highly effective. Incidence, to me, is the only reliable measure we can possibly hope to have to measure, to tell us whether or not prevention efforts are successful. The problem is that last year I headed up the scientific panel for the UNAIDS high-level declaration and commission on HIV prevention. And as part of that, we brought in all the leading incidence scientists, both on the epi side and the actual biology side of the problem. And it was universal. There was absolutely no deviation whatsoever from the group that we're not up to speed. We have never really funded this research. It's never been a priority in the United States or anywhere else. It's a trivial part of all NIH funding for HIV every year, if there even is a funding line for it. We don't even really have a reliable measure of it for the United States of America. And in fact, we've never made the AIDS transition in the United States of America. So I'm not really sure that we can have a whole program that's predicated on the assumption that we know whether or not a country can reliably say that their intervention was successful year to year. Unless we start seriously investing. And by the way, all the incidence measures we have are for the B clade. There have been some attempts to create valid incidence measuring capacity for C and D clade, but they are not in widespread use. The only ways I've seen them applied have been to specifically measure a targeted intervention, such as a vaccine trial. Even then, these are always the weakest parts of those database analyses.
This is great, and I hate
that's
to
fine.
Stop you. Oh, good. Okay. I don't want you to set the precedent for going too long beyond, but it was great. Thank you very much.
Thank you very much. And over the past decade, Mead has been a great person to have a dialogue with, and I guess I'm here as a practitioner and program manager from the discussions we've had in Uganda when I was with OGAC and at UNICEF. And if you look at Roman numeral page 12 of the introduction, he acknowledges my critical perspectives and admits that he was not persuaded. So some of those perspectives are still true, but I wanted to start by giving a couple of positive notes that you didn't cover in your speech, but I think are values of the book. One is you woke me up to the idea of hotspots, that in all but about a dozen countries in the world, generalized efforts at prevention, probably, as UNAIDS said about their prevention efforts in Asia over the first 5 years of this decade, that 85% of the money went to prevent 5% of the infections because it was a very concentrated epidemic. So attention to hotspots, which you've repeated in this book, I think is a valuable underlining of the key populations. Performance-based incentives, which are in addition to COD but different from COD, I think could work, and I'll give a couple examples. In the appendix, you do an attempt at a costing analysis. It makes a couple wrong assumptions that the price of drugs will be steady for the next 30 years and that we'll still treat only people who have CD4 counts of 200 or less. But nonetheless, we need that kind of costing analysis. And so trying to perfect a tool which we can agree on is very important, and you've made an effort here. And we also need milestones to measure progress, and clearly prevalence is a very good one. But I guess my first hesitation about this book and the AIDS transition is that there's an implication that increasing deaths would be an acceptable way to achieve the milestone, which is macabre and it's immoral. And you talk about lower deaths, but your AIDS transitions are taking place in 2020, 2030, 2040, when the incidence based on current prevention models work. And clearly we needed a game changer. And I think the good news is that apparently after this book went to press, the publication of the study 052 is the game changer about treatment as prevention. And the book regretfully misses what I think is the current and will be the next year or two's debate about prevention and treatment, and especially how we use our investments in saying that treatment, the budgets for treatment and budgets for reducing incidence aren't separate. Lowering incidence is shouldn't be a prerequisite for figuring out how many treatment slots you have, but that clearly the benefits of proven biomedical prevention, especially antiretroviral treatment, but also PMTCT, male circumcision, pre-exposure prophylactics, microbicides, how much money should be spent on those compared to behavioral, which have been a large percentage of investment so far, but for which the evidence-based and the cost-effectiveness calculations are much weaker. And PEPFAR has done some modeling, and I take Lori's point to heart that it's difficult to model infections averted, but at the same time, they have found there's absolutely no way to get to the prevention numbers that we want, the lower incidence, without a much stronger emphasis on treatment as prevention. And so the idea that the people who are on treatment aren't transmitting every new sexually acquired infection is in a discordant couple. And if we can lower the viral load of those who are positive, the chances of changing the game and dramatically reducing the numbers of new infections, I think, is much more promising. And there are models that show that this is not just, in even the medium term can be cost effective in terms of orphans avoided, infections averted, and the question of productivity of the people who are back in health. Talk very quickly about performance incentives. It seems to me that the performance-based incentives for things like partner testing for PMTCT outcomes, maternal mortality outcomes, such as having housing for women or paying women to deliver in facilities, there are some good examples of this at a micro scale, and those can be scaled up, and I think that PEPFAR and I hope the Global Fund are interested in that kind of innovation. On the other hand, COD, in trying to imagine how, as a practitioner, how running a program in Uganda, this would work, I didn't find the answer in the book. First of all, you're talking about less than 5% of the AIDS money. The South Africa program is now $500 million a year, and the COD you're talking about is $2 to $3 million a year. In order to do the COD, you'd need a survey, in household survey prevalence study as a baseline. That costs more than $3 million a year. You'd need repeated household surveys and serosurveys to gauge the results. You'd have the evaluator, you'd have the auditor of the evaluator. And I think that the governments of Botswana and Rwanda could probably make this work so that the few $1 million incentive would actually, they could provide the data and give the leadership. But the unmet need is, just for PMTCT, a third of it's in Nigeria. The next largest countries in order are Democratic Republic of Congo, India, Mozambique, and Uganda. And it's inconceivable of me to think that those governments could be well enough organized with accurate data to be able to give the kind of performance measurement for the COD of $2 to $3 million, which frankly is what goes into graft, I fear, in some of those countries. And that, the 2 and 3 million going to the central government may or may not trigger the kinds of innovations and best practices and national ownership that you were talking about. It's not a cash prize that's going to solve our problems in those big countries. Finally, the time frame, I mean, Secretary Clinton did talk about an AIDS-free generation and talked about 2015. And your COD pilots were talking about a several-year pilot just to get the concept established for AIDS. And again, I think the time is now, and there's so many programs that are real-time, that's one that, if it needs to be considered, needs to be rethought of how can we get that to be an incentive for 2012 and 2013, not for 2020. If I have a couple minutes, I'll just mention a couple of questionable assumptions. I think there's a confusion in the book between U.S. leadership and the money, which we're, as Americans, I think we should be very proud that we're providing for the global AIDS response, and for the U.S. having sole responsibility for outcomes. You talk frequently about PEPFAR countries. Well, there are 57 PEPFAR countries, I think, and the focus country idea is long gone. And the countries with the highest prevalence, South Africa, Swaziland, Namibia, Botswana, are in fact providing almost all of the treatment out of their own national funds. So the U.S. responsibility for treatment in those countries is much different than it is in places where that's not the case. And I think we really have to have a much more nuanced perspective of what the U.S. role is in meeting an AIDS transition. You talk still about high resistance rates. Happily, the experience to date is that the resistance rates have been at the low end of the spectrum. I think we have to worry about worst case scenarios, but I don't think we should assume worst case scenarios in the model. You invented the term disinhibition, and you talk about the evidence for that, which is not entirely on one side, but it has not been a major factor in terms of treatment scale-up, but you pose it as almost counterbalancing the advantages of treatment scale-up in some contexts. Talk also about a new entitlement, citing on pages 80 to 83, and the only citation for the creation of this new entitlement is your own work. And then you talk on page 94 about governments creating this new entitlement, but then reneging.
Okay,
and I'm not sure governments have done it.
You're getting too tough.
Okay.
Well,
good.
Well, you can save some of it for the next round.
Great.
I didn't want to stop you when you were defending the U.S. government.
Okay.
I gave you an extra minute on that, but you've wandered into more specific.
Great. I thank you very much.
You're welcome.
I didn't mean to be mean.
Okay, Kenneth.
Thank you very much. I'd like to say that Mead is an old friend of mine, and so I might be a little bit more sympathetic to his case. Although I would say that I would have willingly said before I read this book that Mead had never shied away from controversy. Now I think perhaps he seeks it. So this is a very controversial book, and I think there's a lot in this book for everybody to dislike. And it reminds me of a quote by Churchill, so that's putting you in good company there, Mead, that democracy is the worst form of government, except all others that have ever been tried. So I think the thing for the book is the best way you can read it and the best way you can comprehend it is to try and imagine what else you would suggest. And what we have right now is clearly not sustainable, and I think the evidence in the book is quite clear about that. So what else do you have in mind? And I think that's really what's exciting about the book. The second quick point that sort of comes to mind is essentially what Ambassador Kolkel just said, and this is a bit paraphrasing what he said, which is, I can't imagine how to do this in a particular country. I think it was Uganda that you mentioned. And that's precisely, I think, the point. No one in this room has any sense of how we can solve this problem at a particular location, at a particular time. And that's exactly what cash on delivery is admitting. We don't know the answer. Maybe there's someone else out there who does. How do we get the money in the hands of the person who might have an idea how to solve this problem? And I think that that's where we have to focus on that. So my own particular, the reason I'm sitting on this panel is because I don't have any answers to any questions in Africa. I simply study how is it that other people find answers to questions. And the closer you get to the ground, the more likely you are to find someone who has an innovative answer in particular settings. So cash on delivery has the advantage, and I don't want to use the word incentives. I think that's a pretty bad term, but I'm going to use the other term that Mead used earlier, which is aligning the goals between the donor and the recipient. Instead of funding whatever thing we can come up with based on some budget that we have available to us and thinking of, instead of some sort of irrational funding that hasn't really been thought through, we think, and then combining that with command and control where we try and force people to do what we think they should do, what we want to do is sit down and basically write out what are our goals, what is it that we're seeking to achieve, and how do we align. How do we get the people who we're handing the money to have the same similar types of goals? An additional benefit of cash on delivery is that once we specify the minimum set of goals necessary to implement a cash on delivery relationship, we are, in essence, allowing for innovation in the achievement of the specific goals. And I think innovation is really where, as I pointed out, innovation is really the important thing here. In this particular case, that is the AIDS transition, both the alignment of goals and the creation of innovation are desirable. So first, we all know it's cheaper to prevent than it is to treat. And as of currently, cure is not available. But secondly, and more importantly, the innovation by local actors is more important in prevention than it is in treatment. And innovations in treatment, innovations in prevention are more likely to come from local than they are from international actors. This is because the sciences, the behavioral sciences, the sociology, the psychology, the kinds of things that are necessary to figure out how do we prevent AIDS are the types of things that generally don't have global externalities. When you find the solution for a particular location in Uganda, you haven't found the solution for the rest of the world. You've still found the solution for that particular location. Whereas medicine in general, if you think about treatment for AIDS, this is something which has global externalities. So if you find an answer in one place, you're very likely to contribute to finding the answer everywhere else. So if you're going to have local people focusing on something, you want them focusing on prevention. And let the rest of us worry. Let the rest of the world, let Washington, D.C. worry about treatment. And also, if you want to have someone thinking about prevention, it's better that the local people are thinking about prevention than it is that we, for example, in Washington, D.C. are thinking about how to achieve prevention, because local actors are going to be the people who are more likely to be able to implement this thing. So what we have is a situation where cash on delivery passes the broad goals of the funders. They have to be specified. That's the reason why I say that this is like the quote about democracy. Writing down exactly what it is that we want to achieve and what are the ethical boundaries, carefully defining the ethical boundaries that are going to stay the same for the next 20 years is something that's a task we would all rather not have to do. We wouldn't want to have to specify what those things are, but the reality is we have those beliefs and we need to write them down. Once we've done that, then we release we release this engine of innovation in the local area where within the boundaries that we've specified, they look for the best, the most creative solution to the particular problem of preventing HIV/AIDS. The reason I think that most people have a hard time with this, and the reason that this is going to be a very controversial thing, is that we are all reluctant to give that up. Once we've written down, the 40 pages in which we've written down the ethical restrictions for what we expect people to do, we know in our mind that there's another 40 pages we just couldn't figure out how to write down, and so we're really reluctant to hand anything over to anyone else and say, okay, now you go out and find a solution. What we would rather say is, you tell me what your idea is, and then I'll tell you why it's wrong, and then I'll fix it, and I'll hand it back to you, and then I'll ask you to implement it, right? This is not cash on delivery, right? This is precisely how cash on delivery doesn't work, and the great thing, again, coming back to my original quote, is what we're currently doing, which is we ask people for suggestions, we fix them, we hand them back to them, and we try and force them to implement them. That has failed. So it's time to think of something else, and I think the contribution of this book is not in the specifics, because Mead would be the first person to say he doesn't know the answers in each of these locations, but in the creation of the framework where we try and pass down the incentive for innovation, using the word incentives unfortunately, down to the local area. So thank you, Mead, for this idea.
I just want to say that you filled me with happiness. Those of you who know the history of cash on delivery aid will understand what I'm saying. It's kind of my pet project. And I'm going to take the liberty of interrupting to say two things about what you said that filled me with happiness. One is that you reminded everyone that it is about the relationship between the donor and recipients. That's the point. That's why we started thinking about and talking about this approach at the Center for Global Development, because we are working on the way the donors could do better as much as anything else. So I like that about the relationship. And the second thing is because you use these words of innovation and the engine of innovation at the local level, which is sort of a better way to express that feature that we call hands-off. in fact, it's not necessary that donors be completely hands-off. What's necessary is that they only help when asked. So, and I think the point about the global externalities aren't there for local solutions in the case of AIDS is a really great one. Okay, on to David. Thank you very much, Kenneth.
Thanks,
From
Nancy.
me, if not from Mead.
Thanks, Nancy. Mead asked me to talk about how paying for outcomes could improve national ownership and performance. And let me begin by saying that I think Mead's book is very timely. I think we'd all agree the incentives in HIV are very misaligned. What's happened globally in many countries is we've solved the problem of AIDS deaths, and we've done it at no cost to countries. So we've removed the problem and removed any incentive to change the situation. And that's the reality. It confronts another reality, and that is the global economic crisis is 5 years old, but deficit reduction hasn't even begun yet. And so it's my working assumption that we're at the high water mark of international assistance for AIDS and for health. And so in that context, we have to look at what we can do differently and better. And I think that paying for outcomes could contribute in a number of ways. I think there are 4 major trends that will happen in global HIV financing, and we can link COD to them. First, I think middle-income countries will have to pay for their own AIDS programs almost immediately, and we are largely there. Countries such as South Africa and India are already paying for over 80% of their programs. But countries like South Africa and India can use paying for outcomes for more efficient use of their own assistance. South Africa gives block grants to its provinces. India's NACO gives money to its states. Paying for outcomes could help them to use their own resources more efficiently. I think the second thing which has to happen is most international assistance for HIV is going to have to focus on low-income, high-burden countries, about 20 to 30 countries in sub-Saharan Africa, and that's where global HIV financing will need to focus. But in those countries, we have to achieve better outcomes, and I can see that paying for outcomes, incentivizing prevention, incentivizing countries to worry about the AIDS burden could play an important role. The third thing that I think we all recognize has to happen is we have to be more efficient. As Mead has said, it's difficult to go through 28% year-on-year growth in financing for a decade and to use that money optimally. There are probably greater inefficiencies in HIV than elsewhere. We know of one country in Africa, for example, where 20 to 40% of the whole HIV budget was spent on coordination before a tablet or a condom was purchased. And these are things that cash on delivery, that paying for outcomes can help us to wring out of the system. And then the final thing, which is the focus of so much of what Mead says, is that prevention simply has to work. There have to be incentives for prevention. We have to reward effective prevention. And I think, unlike Jimmy, we have to do it in the context of declining resources. So whatever happens, we have to allocate resources more efficiently, and we have to ensure that countries use mechanisms such as paying for outcomes that utilize the resources more efficiently. So I think it's a really bold book that contributes to a critical debate at exactly the right moment. Thanks, Mead.
Mead, let me ask you 2 questions that come out of the discussion, and then see if others want to say anything.
Number, but it's about a very rare event that is very, very high quality, highly supervised, highly monitored, very, very effective AIDS treatment. So how generalizable that is, as Mike Cohen himself, the principal investigator for HPT 1052, pointed out in the discussion that Nancy moderated last week that you can see on the web, how generalizable that result is to scale up in the general population is something we don't yet know. That said, when one takes that number, that 96%, and one puts it into long-term projection models, either my model or those of many other people, you don't get an answer to the AIDS epidemic. You don't get to an AIDS transition with AIDS treatment alone. And even the one very famous paper, Ruben Granik's paper about South African, that purports to show that one might be able to eventually save money after the year 2030 by universal access. He has a magic trick that he does. He assumes that one of the big things that happens is that behavior changes. And I don't think that's true, and I think that we have to recognize that we don't have the money to do that. Whatever we have the money to do, that's what the AIDS transition's going to do.
Okay.
Yeah, sorry.
I'm just seeing that
I can go
we've
on,
taken a
yeah.
lot, way more time than I should have allowed on the introductory remarks, although they were really excellent. Maybe I could go, Jimmy, do you want to take 1 minute on, is HPN 052 a game changer?
There are plenty of people in the audience who know.
Okay, we'll go back to that. Okay. Okay, so second question, Mead. Lori made the point that it's difficult to measure incidence and it's difficult to measure infections avoided. Don't say too much because we don't want to take too much time. The question I have is, would you want those measured anyway, independent of cash on delivery aid or paying for performance? Is it important that we measure those anyway? Can I say, like Barney Frank does sometimes, yes or no? That's it.
Yes.
Okay. For later, we'll find out. We'll find out why.
It's tough when your boss is your moderator, right?
Follow it up. Do you agree with Lori that this is a problem, that at the moment we don't have a way, the community doesn't have a way to measure these things?
I do agree, and Jimmy made the same point in a way. He said he made it differently. So Laurie talked about the technology, and Jimmy talked about how it would be very expensive to measure prevalence.
Prevalence is easy to measure. I'm talking about incidence.
Well, he was talking about prevalence, but that's right. So you were talking about the technological difficulty measuring incidence. I think that we're on the verge of solving that problem, but people have been saying that about vaccines for a long time too. So I share your hesitancy to be sure of that. That's one of the approaches that we talk about in the book, as you know. But I really think the thing that's ready for prime time now is repeated prevalence measures, and they do cost millions of dollars. And by heaven, when you're talking about $500 billion of potential AIDS treatment expenditure, that a large chunk of which could be avoided by better tracking of new infections, I don't see why we shouldn't be spending millions on repeated, much more comprehensive, much larger prevalence measures, and use those measures to measure incidence.